Okay, well, good morning. So welcome everybody to the Medina Clinic Medical Education Series. So the Medina Clinic is a not-for-profit charitable primary care clinic that is located in Grandview, Missouri in the United States. And it's in the southern part of the greater Kansas City metropolitan area. And so the Medina Clinic has really two missions. One, as I mentioned, it's a charitable clinic. It's a charitable clinic where almost everybody is a volunteer. I myself am a volunteer for the Medina Clinic. And the part of its mission is to serve individuals who don't have insurance for their basic primary care needs. So either they don't have health insurance or they're underinsured. So we're a charitable clinic and we see patients to provide medical care who otherwise may not be able to access that care. So to provide that charitable medical care is part of our mission. The other part of the mission of the Medina Clinic is to provide educational opportunities for individuals to progress in their medical careers. So individuals who are either in medical school or graduated from medical school, to help them move on into medical residency, to provide opportunities for development in order for them to progress. That is also part of our mission. So that's the Medina Clinic. Myself, my name is Wa'il Murad. I serve as the medical director for the Medina Clinic, and I will serve as the facilitator for the educational series. And with us, we have Dr. Sameh Ahmed from Dr. Sameh. How do I pronounce your medical school again? Sorry.
Yeah, it is Durman Islamic University.
Omdurman. Very good.
Durman is a town in Sudan.
Ah, I see. Wonderful.
Yeah.
Wonderful. And then, of course, you have, it looks like your classmate, Dr. Abir.
She is my senior, basically.
Oh, okay.
Yeah.
Okay, well, welcome, Dr. Sameh and Abir. And then we have Dr. Chowdhury.
I'm from Qaid-e-Azam Medical College.
Qaid-e-Azam Medical College, wonderful. Yeah. And then we have Dr. Tahani from Shendi University.
Yes, correct.
Wonderful. Okay, well, welcome everyone. So we'll go ahead and we'll start our session. Now, this medical education series, I want to say that it's geared towards family medicine. Okay, and I believe you guys, as part of your telemedicine rotation, the topic is family medicine, if I'm not mistaken. So, in family medicine, it's a very unique specialty because you're expected to be very good in all of the medical management, topics, basically. So you're expected to manage a broad range of medical issues. And, you're expected to, a good family physician does it well. And so the family physician also is uniquely equipped to be an excellent communicator with patients. And so there are a number of topics that have to do with communication, that have to do with community. And those are some of the topics that I have emphasized initially in this education series. There are board questions related to these topics, actually, and that will serve as sort of the material that we'll be using to go through. And just in full disclosure, the material that we'll be using comes from Swanson's Family Medicine Review. So that's where the material comes from, and we'll be going through it. But just by the fact that we have board questions for these topics tells you that these topics are very important. And I would argue, in particular for international medical graduates, because if we come from a different culture, I think to review these concepts for communication and community health are very, very important to begin to become familiar with. So these are some of the reasons why we're emphasizing these kinds of topics. Today, the topic is how to break bad news. So that is the topic for today. So any questions about that from anybody? Nope.
No.
Okay. Sounds good. All right. Okay. Well, let's just dive right into it, shall we? Okay. So, and then what I would like to do is to talk about how this material resonates with me, actually. In other words, like how this material has been applied or maybe not so applied, and just from personal experience. So I will look forward to sharing what I can there. Okay, so clinical case problem 1, all right? So a 34-year-old woman just diagnosed with metastatic malignant melanoma. By the way, this is something in family medicine that you can really pick up. Sometimes patients, they come in for other things and then you see like a skin lesion, and you're like, you know what, that needs to get checked out, actually. I remember I had not one, believe it or not one, but two pregnant patients I've had maybe a few years apart, where I was seeing them for prenatal care. So just seeing them for prenatal care, and then you notice these lesions, and then you say, you know what, that really needs to be checked out. That's not normal. You know, that needs to be biopsied. And twice it came back melanoma, actually, or those 2 occasions. So, you know, that's one of the joys of family medicine is, you know, you see patients and you're able to help out with the whole patient. So when you experience that, it is very gratifying. And I'll mention. So anyway, yeah, I'll try and mention some of these joys of family medicine as we go along. So anyway, so yes, a 34-year-old woman just diagnosed with malignant melanoma. So you have just received a computed tomography or a CT scan report on a 34-year-old mother of 3 who had a malignant melanoma removed 3 years ago. So look at this. In this particular case, she had the malignant melanoma actually diagnosed and removed. Originally, it was Clark level 1, and the prognosis was excellent. The patient came to your office 1 week ago complaining of chest pain and abdominal pain. A CT scan of the chest and abdomen revealed metastatic lesions throughout the lungs and abdomen. She is in your office, okay? She is in your office, and you have to deliver the bad news of the significant spread of cancer, all right? So this is a big moment, right? This is a big moment. This is going to be something that is life-changing for this patient. So, you know, the family physician, in this case, just kind of needs to be ready to perform. So let's look at the first one. Number 1, regarding the delivery of bad news to patients who are unaccompanied when they come to the office, which of the following statements is true? So let's see what you guys think. Is it A, the fact that the patient alone is irrelevant? Is it B, you have no right to interfere with her decision to come alone to the office? C, you should go to the consultation room and explain that the situation is complex and it would be better if her husband or significant other were present when the test results are explained and treatment options are discussed. Or D, patients do not remember much of anything after bad news is delivered, so it does not really matter whether someone else is present. Or E, having a significant other present will only complicate an already difficult situation. So I'm going to go in order here. I'm going to go in order on the Zoom screen. So the first one is Dr. Abir. What do you think? What answer would you give?
In this scenario, I think C is the most appropriate action.
C, huh? Okay. Very good. Dr. Chowdhury, what do you think?
I'll go with B.
B,
Because It's patient's right to refuse, or it's all like the patient can do whatever the patient wants.
Very good. Okay. So we have, you know, the suggestion is that there's patient autonomy involved, I think. So
Yes, yes.
that leads us to B. Very good. Okay, doctor, who is next here? Let's see. Dr. Sameh, I think you are next. Dr. Sameh, what do you think?
I think C.
C. Okay, very good. Excellent. And Dr. Tahani, what do you think?
I'm thinking of B.
B. Okay. My goodness, we are evenly split, huh? So let me see what I think. By the way, I do not know the answers to these ahead of time, so I'm taking it along with you. By the way, maybe the other benefit to this format, where I'm sort of taking it along with you, is I would like to share like how to think during test taking. So I'm taking it with you. I'm sure I'm going to get some wrong. You know, I'm pretty sure. Hopefully more right than wrong, but you never know. But I'm taking it with you, and hopefully along the way we can share some test taking tips as well. So, all right. So for me, I'm going to look at this. I'm going to say A, the fact that the patient alone is irrelevant. So personally, I'm skeptical about that. I don't think it's irrelevant. I think it's important. So I wouldn't say A. B, you have no right to interfere with her decision to come alone to the office. So I hear what you're saying, Dr. Chowdhury, as far as the autonomy here. I think for me, what gives me pause about this question is it says you have no right. That seems like strong wording to me. So anytime there's strong wording in an answer, it gives me pause a little bit. So I'll put a pin in that. C. Now, by the way, when I look at C, it's the longest answer. So if you have absolutely no idea what to pick, a lot of times the longest answer is reasonable. And then statistically, they say C statistically is usually, like, if you have no idea, C is statistically more common. So those are some things that make C attractive, but let's actually read it. So you should go into the consultation room, okay, and explain that the situation is complex. And it would be better if her husband or significant other were present when the test results are explained and treatment options are discussed. So for me, like, C does not have that strong wording like B does. It allows for nuance, saying that the situation is complex. So C seems attractive, but we'll see. We'll see what the actual answer is. D, patients do not remember much of anything after bad news is delivered, so it does not really matter when someone else is present. So I actually agree with the first part of this. I agree. When patients don't, when you, you know, communicate life-changing things, yeah, a lot of times patients, they may shut down and they're not really listening to you at that point. I feel that that's quite common. So I feel that this first part is, I feel like that's correct, but it does not really matter when someone else is present. I don't know, like, this is actually saying the same thing as A in a way. So sometimes when two answers are kind of saying the same thing, there's a good chance neither of them are the correct answer. So yeah, D does not seem so attractive to me. Now E, having a significant other present will only complicate an already difficult situation. Well, I mean, I think that there's probably a lot of value in having someone else there. And remember, we're in family medicine, so we treat the family, right? I mean, my goodness, when you have kids come in for well child checks, do you ask the, you know, the mom is very important, aside from the legal things that they're minors, but, you know, or when, forget that, we're talking with geriatric patients, right? With geriatric patients, it's important to have family there. if the geriatric patients, if their functionality is decreased, or if there's dementia or something like that. So in so many situations, it's helpful to have family there. So to say that, oh, we don't want family, it'll just complicate things, that's another thing that gives me pause. Since when does a correct answer tell you that things will just get too complicated? I don't know if correct answers usually don't have that on a test. So for me, I think A, D, and E are out. I agree, it kind of comes down to B and C. And just because of this strong wording right here, I would probably lean towards C. So that's how I would go about it. Okay, you guys want to look at the answer?
Yes.
I'll take that as
Yes.
a yes.
Yes,
Good.
sure.
Okay, so number one.
Dr. Murad, before we go into answer, I want to share something why
Please.
I choose C, because I
Yes.
learned that before delivering the bad news to patient, we used to use acronym spikes. So the first thing, setting, we have to meet the patient in an interview, prepare for that.
Hold on.
And
Dr. Abir, hold on one moment. This
yeah.
seems like something we should put on the slide. Give me one moment here. So it's spite.
Spike, S, B-I-K-E, and S, spikes.
Oh, spikes. Okay, Dr. Abir.
So S for setting.
Sitting. Good.
And B is to assess the patient perception.
Patient perception. Good.
Then invitation. I asked the patient if she want to invite her husband or any relatives. Okay, I have to assess the knowledge of the patient regarding this disease or diagnosis, if she knows someone in her family have the same issue or something like that. Then I have to show empathy for sure and support the emotion at that time. Last one, to summarize or to agree with strategy to go forward in planning.
Wonderful.
So
wow.
So when I see answer C, yeah, I remember this spikes.
Fantastic.
But I'm not sure. It could be wrong. I'm not sure. But this is the technique we usually use.
Excellent. Excellent. Thank you, Dr. Abir. So yeah, so let's put this here. By the way, feel free for you guys to share what you know, okay? I think that everyone knows a lot, so feel free. I would strongly recommend, please teach the group what you know. I know personally I would benefit a lot as well. So perfect. Excellent. So, Dr. Abir, we can even apply this, throughout the rest of the session today. So S is for sitting, P is for patient perception, E is for invitation, like inviting significant other, K is for knowledge, E is for empathy, and S is for summarize or strategy. Is that right?
Yes.
Okay, perfect. All right, guys, excellent. So let's, we can apply that throughout. So number one is, all right, so number one is indeed C. Okay, so let's see what the answer says. It says, you should not go, this is going to be interesting, you should not go into the consultation room let me back up. You should go. So the answer says you should go into the consultation room and explain that the situation is complex, and it would be better if her husband or significant other were present when the test results are explained and treatment options are discussed. To have devastating news delivered to a patient in an unsupported environment is less than optimal. If a spouse, son, daughter, brother, sister, or other significant other cannot be present during the delivery of the news, it is useful to invite a social worker, psychologist, or a member of the clergy to be present for patient support. So there we go. Now, A personal experience I had, it was kind of interesting. So there was a patient that we did an endometrial biopsy on. And so we did the endometrial biopsy, and I think during the consent process, of explaining what are the risks and benefits, why we're doing the endometrial biopsy, the patient herself asked for the results, can she come in with a significant other? Now, what was interesting is that this was during COVID, and there were restrictions in the office on limiting the number of people that can come in, and the patients were not to bring anybody else with them because, during COVID, we wanted to minimize the risk of community transmission in the office. So she said that, and I think, we talked about, we have this going on with COVID. And actually, during the procedure, she wanted someone to be present when we got the results of it later, like maybe several days later. And so what we talked about, and actually come to think of it, that I take that back. She said that after the procedure, actually. Yeah. During the procedure, she was very anxious. So we consented her. We said why we're doing this. And we talked about how the results would come back in several days. Then we did the procedure. During the procedure, she was extremely anxious. And we had a behavioral health clinician in the office actually be with her during the procedure, which is it's a standard office procedure, but she was very anxious. So the behavioral health clinician was with her, holding her hands, consoling her. And then after the procedure, she said, can someone come with her when she gets the results? Now, what's interesting is that we talked about how, well, we have these restrictions because of COVID, and we offered to say, well, what we could do is we could have the behavioral health clinician with you at the time that we discuss the results. So we can do that just like the behavioral health clinician was there during the procedure. And what did she say? I think she reluctantly agreed, I think is what it was. I think she reluctantly agreed. And to be honest, I think in retrospect, if we were to do anything differently, it would have been to really work with the rest of the administration to say, hey, this is probably a special case where, yes, we need to make a special exception to our COVID rules to have a significant other come in. I think if I were to do anything differently, it probably would have been to do that. So what about you guys? Do you guys have experience delivering bad news?
Yeah, sure.
Would you like to share a story?
Yeah, there is a lot of stories, basically.
Yeah, I bet.
It's very common to face this situation.
Yeah.
But as Abir said, we have to follow the rules of spikes. Yeah.
Oh, right, spikes. Yeah. Do you guys have observations on delivering bad news with family, without family, anything about that?
I have one with family, basically.
Mm-hmm.
That was delivering bad news of renal failure, and the patient have to start dialysis.
Yeah.
In the stage renal disease to start dialysis.
Yeah.
So the consensus was.
How did they take it?
Yeah, it was not easy, basically. The one who got in shock, not just the patient, but even whole family members.
The patient didn't even what?
His family members.
Oh, the patient didn't even tell them?
No, all of them was there, basically.
Mm.
Yeah. we told him in presence of his family members. Yeah, so yeah, whole the family got in shock, but basically his family gave some support.
I see.
Yeah.
See. Yeah. Yeah. Yeah, it's interesting. When you mentioned that, it reminded me of something at the Medina Clinic. So the Medina Clinic, like I mentioned, it's a charitable clinic. It's something that myself and other people volunteer for. I have my own full-time job. But I remember one time, actually, it was a long time ago. This was when I was probably recently out of training, I want to say, but there was a gentleman from Egypt, actually, that we were seeing, and he was there with his son. And what was interesting is he also had renal failure, but it was not diagnosed previously, apparently. I mean, his GFR was like 8. He had basically end-stage renal disease. I believe he was a diabetic. It was a long time ago now, but basically, I remember he was there with his son. Now, his son was there. This was part of routine follow-up, actually. And I remember we're talking about the renal failure, and it wasn't clear, maybe it wasn't clear to me that they were not aware of it before. But, I wonder if it was not delivered the best way, because we're talking about how the renal function is very bad. And I think probably what I did is I was just talking about it. And then I think I'm wondering from the son's perspective, it was like, whoa, what's going on? And, I think I could have set that up a little bit better. And what was interesting is that it was the son who started crying, actually. It wasn't the patient. Of course, the patient is getting the information from the son. So the patient may not have been understanding everything fully. But yeah, it was the son started crying, actually. And it was a tough situation. So, I think that probably if I were to do it over, probably like the SPIKES acronym that we talked about, some of the other concepts that we're talking about here would have been helpful, because I think at the time I treated it like any other diagnosis, but I don't think I treated it like this is devastating, life-altering, information. Yeah. And I think probably it could have been set up a little bit better. What ended up happening with that patient, ultimately, we tried to help as much as possible. Of course, in the United States, if you don't have insurance, dialysis is like, I don't know. I think, if you have end-stage renal disease, you might qualify, that I think that's one of the conditions where you can qualify for Medicare, I believe. But anyway, this particular patient, because of his immigration status, he didn't even qualify for Medicare. So yeah, dialysis was not an option, and he needed it. So it was very difficult, and they decided to take him back to Egypt. And I was trying to emphasize, okay, he needs dialysis. He really needs this. And, they went to Egypt, and then they said, no, the doctors say he's fine. And I'm like, what do you mean he's fine? And then several, I don't know, maybe within the next year, I think he passed away, actually. So yeah, and I don't know, maybe, if they really want to do dialysis in Egypt, they probably could have. And actually that was one of the options, is to say, look, if you're going back to Egypt anyway, you could do maybe dialysis there. But it was very interesting, because the whole time, actually, I remember when talking to them, they were like, oh yeah, the doctors, they prescribed something for GI, something for nausea, and this and that. And it was funny because he had renal failure. And I'm like, this is what he has. And I fully expected him to do dialysis in Egypt, and he didn't. And so I always wonder, maybe had I done a better job discussing this and treating it like the bad news that it is, would that have had an impact or not? I don't know. I don't know. But this is, gosh, you know, as we're talking, there's lots of times, I remember one time, I mean, so I do a lot of maternity care and obstetrics. So usually, so what will happen is you meet a lot of women with miscarriages, and that is a great chance to practice delivering bad news. It really is. I mean, the miscarriage is sad, but boy, that is the perfect time to do a good job delivering bad news, because all of these concepts come up. So I think those who do a lot of maternity care over time, I think, get very good at this, as I'm sure a lot of other specialties do. But. Okay, that's enough of that. So let us move on to number 2. Okay, guys, which of the following settings is not acceptable for the delivery of bad news? Is it A, a physician's office, B, a quiet room in a hospital setting, C, the patient's home, D, a private hospital room, or E, a multi-bed hospital room? What would you say?
A, E.
Okay, we got 1 vote for E. Who is that? Dr. Abir?
Yes.
Okay, Dr. Chowdhury, what would you say?
I'll go with E too.
E, very good.
Yeah.
Dr. Sameh?
Yeah, I think E.
E, good. Dr. Tahani?
Yeah, E.
Very good. And I would agree. I would agree. So let's see what the answer is. This is a pretty straightforward one, but let's see. Number 2 is E. So, so the answer is this. So it's E. Actually, hold on, let me hold it. So a multi-bed hospital room or an exposed area of an emergency department, so exposed area of an emergency department, is not an acceptable location for the delivery of bad news. Patients in beds next to your patient obviously will be able to hear all or most of the conversation. Being in an exposed area would add to patients' feelings of vulnerability. Just pulling a hospital curtain is not an acceptable option. When breaking bad news, attention to privacy, the physical environment, and the presence of a support person are all important. Obviously, other alternatives in the question are acceptable, okay? So physician's office included. A quiet room in a hospital setting. You know, there was one time actually we had a lady who came in labor, and then she make long story short, she had a uterine rupture. She had severe pain. We were fortunate to be able to do an emergency C-section, delivered baby. It was a uterine rupture, actually. Actually, it was a very interesting case. We published it. If any of you are curious, we actually published this case, by the way. You can actually look it up on PubMed. So anyway, the baby was delivered. Mom was in a critical situation. You know, she lost a lot of blood. Oh gosh, what happened? Yeah, she actually had to go back to the OR. Actually, she did okay. I should say after the C-section, she did okay. And then she developed later intra-abdominal bleeding, had to go back to the OR, and then she was critical. Okay, so then let's see, what happened? Also a long time ago. All these things are a long time ago, actually. But the family, so then she became critical, and then we had to discuss it with the family, actually. And you know, what we did was we found a conference room in the hospital to discuss it. We didn't discuss it on the floor. You know, a patient's room would have been acceptable, but she was actually in the ICU. And so the ICU, probably, you know, we could close the door and probably talk. That would have been acceptable. But we talked in the conference room, and maybe that was a little bit easier because the patient isn't right there when talking about it. But anyway, that's what we did. And we discussed it, and they were actually, it was very interesting because they were not in a good place. They had a mix of emotions. They were very devastated. They were very probably angry and upset. They probably felt very like uncertain, probably vulnerable. Like they were just not in a good place. And you know, that conference room, maybe a little bit more comfortable than some of the other settings, that was very important because the situation was already difficult. Sometimes, depending on the people you're talking to, delivering bad news can be easier or harder. And this was not easy because there was not a high level of trust, I think, at that particular moment in time. And you know, we did our best to be professional and you know, appropriate, and you know, to give hope to the situation and so forth. And that setting, I think, really helped. And I think, and what ended up happening, fast forward 5-6 years, the mom of that patient, she was a nurse, and she was actually my nurse later, interestingly. And then actually we published that case. And that baby that was delivered sorry, I'm going off on a tangent now, but this was an early experience of delivering bad news, actually, when I got out of training. But let me think. This happened in 2009. This baby is now 12 years old now, actually. So
Wow, that's interesting.
Yeah, interesting case. Yeah.
Wow, very interesting case. Yeah.
Yeah, it was very interesting. So it was very good because these things teach you things. It taught me some important concepts of delivering bad news, because definitely that was involved. And heck yeah, if you guys want to look it up on PubMed, it's there. So
Okay.
uterine.
Yeah, we will.
Anyway, so it's interesting because, you know, in getting ready for this topic, I'm like, yeah, I guess there are a few cases. But then the more we talk about it, I'm just remembering, I'm sure you guys are too, just remembering all these different situations of delivering bad news, you know?
But basically, Dr. Murad, when you was talking to her, you was in the ICU, right?
At that time, she was in the ICU, yeah.
So ICU is not multi-bed room.
ICU is not what?
It's not a multi-bed room.
No.
Ah, okay.
No, ICUs are generally not. I've never, I mean, personally, I've never been in an ICU that was multi-bed. I mean, the ICUs, their beds are like, they're in rooms. You have the ICU, and then you have maybe like a dozen rooms or something like that. And then, but the rooms you can close, you can either, you know,
Separated.
yeah, it can be private. It can be private.
Okay.
Yeah. So, yeah,
Okay.
so definitely, and goodness knows, you have a lot of family conferences in there. So, but yeah, no, it's private, and for probably, you know, for this reason. So,
Mhm.
Please, Dr. Murad, may you provide us with a link or DOI for this article? I'm curious to read about it.
I was half joking, but if you just Google Murad uterine rupture PubMed, it'll come up.
Okay.
Okay, thank you.
No problem. So yeah, so you can see this. Every case can teach you a lot. This case taught us a lot about, you know, communicating, delivering bad news. Also, the medical management. It was enough for a case study. You know what I mean? So patients, they teach you a lot of things. So, all right. So number 3, look at this. The acronym may come in handy here. So let's see. The first step in breaking bad news is what? Is it A, deliver the news all in one blow and get it over with as quickly as humanly possible? B, firing a warning shot that some bad news is coming? Is it C, find out how much the patient knows? D, find out how much the patient wants to know? Or E, tell the patient not to worry? What would you guys say? Here's the acronym.
I would say C.
Okay. Okay, so we have one vote for C. That's Dr. Abir. Okay. Dr.
For C.
Was that?
I'll go with C too, because the second part of the spike was to have a perception how much the patient knows.
Right.
So, yeah.
Right.
I'm going to C too.
Yeah. You know, on this one, I happen to actually know the answer to this. So on this one, I believe the answer is B. I believe, but let me double check. I happen to know it because I read on this recently, but let me take a look. Number 3, like a warning shot, like I'm going to deliver bad news, or, you know, but let's see. Number 3 is, yeah, it's B. So actually this is good. This is like a little modification to our acronym. So it's sort of before, it kind of comes here, I think. But let's see. Let's read the answer. Oh, excuse me. Okay, B, a warning shot. So a warning shot prepares the patient psychologically to hear something negative. Continuing with open-ended questions to assess her understanding of the disease, as well as her readiness for detailed information, allows for prioritizing the information provided. It is critical to check in often using questions such as, how are you doing with this information? And expressing empathy. So it's actually interesting, we're going right through that acronym. And expressing empathy, and you can express empathy by saying, this is very difficult news to handle. Patients are not likely to retain all the information that could be provided in that first setting and should be scheduled for close follow-up to review the information and plans. So it looks like, what do you guys think? It looks like the warning shot to tell them, you know, to warn them that they're going to hear bad news or they're going to hear negative news. Where would that fit here, you think?
I think in the setting to prepare the patient for bad news.
Yeah.
And then ask that how much you know about your condition.
Right, exactly. And when you ask how much they know about their condition, do you think, does that fall under where? Patient perception or?
Yeah. Yes.
Okay.
Yeah, yes, perception.
Okay, got it. Good. Okay, so that falls into the sitting part, you guys think?
Yes.
Okay. So sitting.
So regarding the patient perception, usually ask the patient, what do you know about the disease? What it could be? So sometimes the patient said it could be maybe infection.
Right.
So I will say, no, it is more than that. It's more difficult than that. So at this point, I prepare the patient. The coming is the worst.
I see. Okay. Very good. Absolutely. Yeah. I think that all makes sense. I think that's all very good. Yeah, I'm just taking a look here, and yeah, I think this information, it meshes well with our acronym. So okay, well let's move on to the next case. So that was very good. So clinical case problem 2, communicating bad news. So a patient has had a breast biopsy for a suspicious lump seen on mammogram. The pathology report shows an adenocarcinoma. Arrangements for the patient to come to your office today 3 days after surgery were made when she left the surgery center. By the way, this is, I think, a good thing to do if you're ordering a biopsy or ordering, let's say, STD testing or testing for sexually transmitted diseases. That's another situation where you may have to deliver bad news. So, to say that you have chlamydia, or you have maybe even more of a another life-altering one is HIV, for example. So to make the appointment to discuss the results is probably better than calling the patient and saying you need to come in to discuss this. What do you guys think? I see here in the case, what sticks out to me is she got this biopsy, and then the patient was scheduled to come in 3 days later before she left the office for after she had the biopsy. That day, she got the biopsy, and as she was leaving, she made the follow-up appointment to discuss the results. So she had that appointment already scheduled. So basically, that's better than they leave, they have no follow-up appointment, and then you call them and say, you should come in so we can talk about this. I mean, I guess that's one way of doing a warning shot, that's one way of doing a warning shot, but that may not be the best way to do a warning shot, like on the phone saying you need to come in, because that just puts them in a high state of anxiety until they can come in. So anyway,
that makes sense.
Yeah. So ideally, you schedule them. If you're doing some testing for something potentially life-altering, then it's good to schedule the visit for them to come in to discuss it, basically, before they leave the office. So
yes.
Okay, guys, let's see what the next question is here. So, okay. Which of the following were appropriate steps to have taken? All right. Discuss with the patient and her husband before the biopsy that oh, interesting. I wonder if this is sort of what we were talking about. Anyway, discuss with the patient and her husband before the biopsy that you would like them to make arrangements for someone to drive her home if it is bad news. Is it B? Should suggest that she have someone accompany her to the follow-up so that there will be 2 sets of ears to hear the results and to recall the explanation and any plan for additional follow-up? Is it C? Have your office call the husband when the report comes back positive for malignancy and demand that he accompany his wife to the follow-up visit? Is it D? Check the next of kin listed on the hospital record and call that person to come to your office in case the patient chooses to come alone for the follow-up? Okay. Or is it E, none of the above? What do you guys think?
I'll go with B.
B, very good, Dr. Chowdhury. Excellent. Okay. What do you guys think? Dr. Chowdhury goes with B.
The first part of the A makes sense, but the last part, I don't agree with it.
I see.
So
I'm agreeing with Dr. Chowdhury. For me, B makes sense.
Okay, so we have 2 votes for B. Anybody else?
I'm thinking of E.
E. Yeah, E is an attractive option, you know, like all of the above, none of the above, you know, that certainly is a reasonable. Okay, who has not commented? Dr. Tahani, did you comment?
Yes, I said E.
Oh, you said E. Oh my goodness, Dr. Tahani, I'm so sorry.
Yes.
Okay.
That's okay. No.
Who didn't, who's, this is good test taking practice, actually.
I will go with E too.
E, oh, wow. So we have 2 for B, 2 for E. Oh my goodness, we have a split decision. Okay, this is why it's good to have an odd number of people, right? So, you know, let me think. Okay, so A, discuss with the patient and her husband before the biopsy that you would like them to make arrangements for someone to drive her home if it is bad news. Yeah, you know, yeah, that second part, I agree. It sort of makes you think, you know, I don't know. There's something about that that makes you take pause. I like the fact that you're talking about like planning ahead of time, like you guys suggested. So A, I'm not going to rule out. I'll put a pin in it. So I'll put a pin in it for a second. Let's go to B. Suggest that she have someone accompany her to the follow-up. That sounds good, right? So that there will be 2 sets of ears to hear the results and to recall the explanation and any plan for additional follow-up. Yeah, that I, you know, that seems that sounds reasonable to me. B does not give me the same feeling like A did. So I might rank B over A, you know? So A, I put a pin in it. B, I like the fact that planning ahead, and why else do we have family there? So that they can listen too, you know? So I like B for that reason. So B is over A. C, have your office call the husband when the report comes back positive for malignancy and demand that he accompany his wife to the follow-up visit. I agree, C, you can just immediately throw out. There are, I think, multiple things wrong with this question. First of all, have your office call the husband. Why would you call the husband? You would call, if you're gonna call anybody, you would call the patient. You know, actually it's kind of, it's patriarchal to me. So why would you call the husband? Anyway, and then you're calling back. Not just that, but you're calling back saying, oh, by the way, you have cancer. So you're not calling the patient. Actually, this answer is kind of, if it weren't serious, it'd be funny, actually. So you're calling saying, yeah, you have cancer. And by the way, I'm talking to your husband, not to you. I mean, what is this? By the way, and you are demanding, right? I think anytime you have an answer, you know, you're a doctor. You know, it's just not, you know, that's just not a routine thing that we do. I mean, on a test, we're not going to demand things, okay? So I just think that seems a little weird that he accompany his wife. Oh, by the way, what else is wrong with this? Who even said that she would want her husband, right? Maybe she would want her sister or her mother or a friend or a daughter, you know? So you're essentially forcing the patient that it's her husband that's going to come with her. So there are like 4 things wrong with this question, this answer. Guys agree? I think there's also
Yes, totally agree with you.
Yeah, it's against the autonomy as well.
It's patient autonomy, exactly. Yeah. And there's no spike acronym. Actually, it's kind of a joke, actually. So anyway, yeah, this one you throw out. Check the next of kin listed on the hospital record. Oh, okay, that's better, right? So at least you're checking the hospital record and not just assuming it's her husband, but check the next of kin listed on the hospital record and call that person to come to your office in case the patient chooses to come come alone for the follow-up. This one also you can just immediately throw out. So let me get this straight. You're going to have the patients come and she's going to unexpectedly see someone else that you picked to come to join her. Yeah, that's one way to tell her she's getting bad news, I guess. So my goodness, these scenarios are too much. So yeah, C and D you throw out. Okay, so then there's E. So if I'm going to go with E, that means that something needs to be wrong with B. So is there anything to me? Let me guess. So for you guys who picked E, what about B? Presumably something about B gave you pause, right? So please share with the group in case we may have missed something. What is there anything about B that gave you pause?
To me, the last part of this answer, that there will be two sets of ear to hear that, we need someone accompany the patient just to support her. Not it seems for me like my patient not competent enough, not mature enough to hear and recall the diagnosis. But yeah, this is what I feel about this answer.
Gotcha. Very good. Yeah, because we are, our patient, we are giving the patient the respect that, we we don't assume that she's not competent to process the information. So we're giving that patient that due respect, it sounds like.
Yeah, I was thinking at the beginning of B, but also the end part of B. Yeah, it shows that the one who wants him to be with her for support more than to recall the explanation and the plan.
I see. Got it. So, so yeah, so the expectation is that the person who's coming will be primarily a supportive role. So I think for me, when I look at it, for me, I feel like it's all the same. So I have a hard time distinguishing support, like emotional support, from, processing the plan. And for me, a lot of times, like in the office, I am very grateful for the times when a family member, maybe they may reword something I say. Like, for example, I'll explain something and maybe the family member understands it better than the patient, and they reword what I said to the patient, or they rephrase what I said to the patient in a way that the patient understands. So that's an experience that I have. And for me, for that reason, I feel that because of that, it's actually maybe a good thing if they hear it, because they can actually help, they can aid me in communicating information to the patient. So for that reason, I might go with B. But let's see what the answer is, shall we? Okay, answer is, it's almost like a game show almost you can turn this into. Okay, it is B. Let's see what the explanation is, shall we? So, okay, so what should we do, right? What should we do as family physicians? So basically, you should encourage her to bring someone with her to follow up, to increase the retention of diagnostic information, as well as any further diagnostic or treatment steps that are necessary. Okay. It is important for your office to call someone to join the appointment, or I'm sorry, it is inappropriate, It is inappropriate for your office to call someone to join the appointment without the patient's knowledge and consent. Yeah, I think that's talking about D. That's completely out of bounds, to do that. It can be as important to have someone accompany a patient even when the diagnosis is not bad news, because the stress of anticipating the stress of anticipating bad news can diminish the retention of information, such as follow-up evaluations and medications. So, any questions you guys have on that?
No, it makes sense now.
Yeah. So I think it's reasonable when delivering bad news, it is reasonable that any normal patient will have difficulty retaining information, processing information. And so to enlist the support of the significant other when discussing this information is very appropriate for your typical patient. So, okay. So yeah, and I like the comment too. It can be as important to have someone accompany the patient, even when the diagnosis is not bad news, because the stress of anticipating bad news can diminish the retention of information, such as follow-up evaluations and medications. So for me, what that means is that, let's say that, like, this lady, she had her biopsy, she went home. Now, look, she just had her biopsy, so she's already stressed out, right? So, without doing anything, she's already stressed out for those 3 days. So even if the result is not cancer, right? Even if it were not cancer, she may need a follow-up mammogram, right? She may need a follow-up breast ultrasound or something. She may need education. Maybe if someone chooses, she may need education on self-breast exams. Who knows? So even if it's not cancer, you're still going to discuss with her a plan. Even if it's not bad news, she still may have trouble processing the information just because she's been so stressed out over these 3 days. So, that's I think an important point as well. Okay, shall we move on to our next one? Excuse me. All right. So, which of the following steps might be considered a communication aid and be helpful to the patient in the days after a diagnosis? Is it A, an audio tape of the consultation discussion when you shared the results and plan? Is it B, a patient education handout that discussed the same material you discussed? Is it C, a follow-up letter after the consultation reiterating the information shared at the consultation? Is it D, a phone number of the last visit you treated who did well? Or is it E, A, B, and C? What would you guys say?
I would say C.
C, okay, 1 vote for C. That's Dr. Abir.
Yes.
Okay, what else? What the rest of you guys, what do you think?
No, C too.
C, okay, very good. That's Dr. Tahani. Okay, Dr. Chowdhury and Dr. Sameh, what do you think?
I'm confused between B and C.
Okay.
I'm not sure, right, Silly?
Sure. So let me share one thing about test taking is that, especially with multiple choice questions, one thing is that you don't necessarily have to know the answer to get it correctly or to get it correct. So a lot of times what you want to do is you're not picking the absolute right answer. What you're doing is you're almost ranking them, So you may not know the answer. Maybe it's B, Maybe it's C. Don't know. Maybe they're both, they both sound right, possibly. So the thing with test taking is what you want to do is you want to use what you know for sure to help differentiate which one is closer to what you know. Or based on what you know, which one would be ranked over the other one? Does one of them give you a bad feeling, or is one of them kind of make you skeptical, whereas the other one doesn't? Do you know something where one of them is closer to what you know? Does that make you rank higher? So think of it in terms of, I don't know which one is right, but which one would be ranked above the other one? So try and think of it that way.
So then I'll go with B.
B, okay. Sounds good. All right. So it sounds like we had, okay. So that was Dr. Chowdhury. Did Dr. Samah weigh in or not?
Yeah, I'm here.
Oh, Dr. Samah, what did you say?
Still I'm between B and C. But
Oh, okay. Same thing. Same thing. What did you say?
Okay, we'll go with C.
C, okay. So I think we had 3 votes for C, 1 vote for B, right? Is that right? So let me take a shot at this. An audio tape of the consultation discussion when you shared the results and plan. So what's interesting? I remember I had a classmate, in graduate school who was working on a project to do something like this, to do like a recording to make it available, for reference for the family. And I think this classmate, I think was an oncologist actually. So as an oncologist, my goodness, doing a lot of delivering bad news. So I feel that's an experience I have. That's something I know. So I'll put a pin in it. I don't know for sure, so I'll put a pin in it. B, a patient education handout that discussed the same material you discussed. Well, as a family physician, I feel like I do this a lot. So I think B is pretty standard. So I like B. So let's look at C. A follow-up letter, so this is interesting, a follow-up letter after the consultation reiterating the information shared at the consultation. Okay. Yeah, I think, I admit this is not something that I routinely do. So have I seen people do it, or did I read about it? I can't say that I've seen this specifically done very much. To me, this sort of ranks the same as A. It's kind of similar to A. So, I like B. A and C are kind of the same to me. I might give B an edge. So D, a phone number of the last patient you treated who did well. So this is, I think this is a reasonable, this is something reasonable to do, but the thing is you need consent, obviously, from the last patient to do that. Yeah, so I feel like that's reasonable too, although it's not something that I've done routinely. Maybe it's something to consider doing in the future, but. And then you have E, A, B, and C.
Yeah, why not E, A, B, and C? All of them reasonable.
Yeah. I admit, I don't know, like I like D, to be honest. Like if it said A, B, C, and D, I would probably pick D. Like I feel like that's fine as long as you have the consent. But who said that? Dr. Abir?
Yeah, I said E.
E, yeah. So you like them all, huh?
Yeah.
Yeah. I mean, I think that, we do send letters to patients with things. it's not unreasonable to send patients patient education stuff. So yeah, I like B better than A and C, but they're all reasonable to me. This D, I feel like you just need their consent, the consent first. So yeah, and it's interesting. The phone number of the patient, the last patient you treated who did well. I mean, sure, yeah. Does it have to be someone who did well? I guess that would help, wouldn't it? Yeah, I guess if you have to pick one, I'd probably go with E, just because I had A, B, and C sort of clustered together. Maybe there's something wrong with D, so I'll go with E. Okay, you guys ready to see the answer?
Yep.
Number 5 is, it is E. It is E in this case. Let's see what they have to say. Let's see what the commentary is. So the National Breast Cancer Center and National Cancer Control Initiative in 2003. Actually, that brings up another issue. Let me see when this material was copyrighted. 2013, nope, 2017. So it's not that bad. It's 4 years old. 4 years. Should probably, let's see, we need to see if there's a newer edition. But 2017 is not too bad, actually. At least it's not more than 10 years ago. That would be bad. Okay, the National Breast Cancer Center and National Cancer Control Initiative in 2003 suggested that the patient's understanding, recall, satisfaction, and care of, or all three, understanding, recall, satisfaction with care, satisfaction with care, excuse me. All of these 3 outcomes are increased with communication aids. So it's interesting, like the family can be a communication aid actually, and here we're talking more about communication aids. These included provision of a tape of the consultation, sending a summary follow-up letter, or having a support person present during the consultation, or both. Okay, all right. So there's the tape, or in sending a follow-up letter, and then the support person we talked about. Now, this is very interesting. Giving one patient another patient's phone number without significant pre-planning and permission would be inappropriate. Okay, so that's why D by itself, because I think when you look at D, it's almost suggesting like the patient comes in and then you're like, here's a phone number. And I think that the way it's phrased gives you the picture that here's a phone number, just call them. It's almost like it's implying that the other patient who did well was not consulted, you didn't get permission. That's what it sort of implies, you know? Maybe if D said, give the phone number of the last patient who consented to doing this and was fine with you doing this, if D had that information, then it's clear that there was significant pre-planning done. So I think the fact that it's almost like here, just call this person. That's what it's sort of suggesting, I think. So that's why D is not appropriate. So, okay.
Regarding the answer D, in our home country in Sudan,
Yep.
there's a lot of community organization to support patients. Like we have friends of cancer patient, friends of diabetic patient. So if the patient newly diagnosed as diabetic, we give them the website or the phone. They already consent to support that patient.
Oh, wow, I see.
So it's very helpful. Yeah, we have many of them, like celiac disease, friends of celiac disease, friends of cancer patient. It's very helpful because the patient will find the support from the people who went through the process the patient
I see.
received now. Yeah.
Wonderful, wonderful. Yeah, that's very impressive, very impressive. So you know, and even that could be something here, is that, you know, you provide these communication aids, and then, you know, to connect them, you know, like you give them, here's some information, but then here's also connection with an approved support group, you know. That's very good. That's very good, Dr. Abir. Thank you. And I did not know, in Sudan that there was like plentiful opportunities for these support groups.
Yeah, there's a lot, because many of patients underserved or uninsured, so the community organization or charity, they provide this support to patient, like emotional support, and also something like drugs or shelter or something like that.
I see. Wonderful, wonderful. That's great to know. And it sounds like these organizations, they're done by like, they're not done by outside organizations, like, you know, they're not done by outside, like not-for-profits from other countries like the US or others. This is like, these are native support groups.
Yeah, most of them, yeah.
Yeah. Very good. Oh, that's very impressive. Very impressive. Thank you. Thank you for sharing.
Yeah.
Hey guys.
I have a question regarding choice A.
Oh, yes, please.
For audio tape, do you have to ask patient first before recording the consultation discussion?
I would think so, yes. Yes, absolutely. I think that, yeah, definitely consent is very important prior to recording. And to be honest, a lot of times patients, they come in with their cell phones and they'll record on their cell phones, actually. Hopefully they tell you. Hopefully, yeah. But especially, yeah, with the availability of the cell phones, it can be very easy. You know, it's interesting. It says audio tape, actually. I think if this material were published in 2021, they may not say audio tape. But in any event, yeah, potentially, yeah, you can, with consent, they can even record it on their cell phones. You don't even have to send it to them. So.
Okay, thank you.
Yeah. So, very good. I guess another question is, does the doctor's office want to have this recording as well? That's a whole nother administrative question. Okay, number 6. All right, which of the following statements regarding finding out how much the patient wants to know is not true? So let's look at our SPIKE acronym. So this is, I think, knowledge, right? I think we've kind of gone through patient perception and invitation. It sounds like we're on knowledge. So finding out how much the patient wants to know is not true. What do you guys think? What do you guys think?
What about E?
E, okay, Dr. Abir picks E. I just want you to know, getting it right or wrong has no impact on a letter of recommendation, just so you guys know. So you can relax. It's okay.
I'll go
We
with
are competing ourselves, Dr. Murad.
What was that?
Not about letter of recommendation, but you know.
Yeah, it has no
Since-
impact. Just don't worry.
No, we know that, Dr. Murad, but we're trying to understand it very well. It's so interesting physically.
Good. Don't want you guys to worry.
Yes, that's okay.
So I'll go with E because I think that the patient has right to know the full extent of the condition.
Okay, very good. That sounds reasonable. Okay, we
I'm
had
going to see it too.
Okay, 3 votes for E. Anybody else?
They said it's not true, right?
Is not true. Yes. Ah, that's not true. Yeah. You guys want to make sure you pay attention to that.
I'm thinking about A.
Okay. Got A, okay. Okay, are you guys good with your answers? You can change it. In case you didn't catch this part, which is not true. That's something that you have to be careful with the questions. They say all of the following are true except, you know? So you're looking for the bad one. You're not looking for the good one. Usually when you look at multiple choice questions, you're like, okay, which is the right one? But sometimes they're all right except one is bad. So you're looking for the bad one. So that's just be careful about that. You guys good with your answers or?
Yeah.
Okay, let me see. Let me take a shot at it. Which of the following statements regarding finding out how much the patient wants to know is not true? Every patient would rather not know all the details of their disease. Well, I can tell you right off the bat, that's not true. That's just experience, I think. Definitely, there are some patients that want to know every last thing. There are certainly lots of patients who don't want to know everything. There are some patients who want to know everything. So when it says every patient would rather not know all the details, that to me, it doesn't ring true. The other thing that makes me suspicious about A is that it says every patient. I just get very skeptical because patients are different, people are different. So when it says every patient, it better be something very, very very major, or maybe it needs to be something very specific, or it needs to be something, I don't know, like you treat every patient with respect, but to say when it talks about every patient's preferences, they're not the same. So anytime things are universal, all the time, never happens, every patient, you always get suspicious about that. So that's why A is kind of, I like as an answer for this, I think, but let's see what the other ones are like. Some patients would rather not know all the details of their disease. That sounds right to me. Some patients would rather not know. Yeah. And you can see that A and B both can't be right, actually. C, most patients initially do not know how much they want to be told. And that to me seems probably right, actually. There are lots of times patients actually, sometimes we assume a lot of our patients and we assume that they know a lot of things, but it's important to question those assumptions. So actually a lot of patients, especially if we're talking about something new, something maybe life-changing, this is new for them. They don't know a lot of things about it. So this potentially could be true. The other thing to me is that B and C logically both could be true, but A and B cannot be true, A and C cannot be true. You see what I mean? A and C cannot both be true. So, yeah, more or less. If I had to pick, I think A is probably most right. C, I mean, I don't know absolutely about C. I feel like that's probably true, but C is probably ranked second. B is ranked third for me. Some patients want to know the whole truth right away. Yeah, that to me rings true. Some patients want to know everything right away because that's their personality. So that could be true. And so you see here with B, C, and D, it says some patients, most patients, some patients. Like, see, there's nuance there. Not like A says every patient. I mean, my God, really? Every patient has that preference? I don't know about that. And B, C, and D can all be true at the same time, by the way. So let's look at E. In some instances, patients should not be told the full extent of the condition. Yeah, that's in some instances, I can see how that can be true. They may not be ready. They may not have a significant other with them. I mean, there might be a lot of, they may not have capacity to process the information. You know, especially if they're acutely ill, you know. So E can be true to be. So for me, I think, to me, it really sounds like A for these reasons. And by the way, B, C, D, and E, they can all be true at the same time, but A cannot be true at the same time. I mean, I guess technically A and D technically can be true at the same time, but look at A and D, even but they're saying different things. D is saying some patients, A is saying every patient. So actually, no, they both can't be true if you think about it.
I think A because every patient, yeah.
Yeah. So anyway, let's not beat a dead horse to death. I think that's what I'm kind of leaning towards. But let's see. But anyway, that's just like my rationale for picking A. Yeah, anyway, let's take a look. So number 6 is, yeah, 6 is A. Okay, let's see what's going on here. So most patients, so let's find out what the actual facts are. So most patients will want to be told the whole truth, but there are some exceptions. Okay, there we go. So C is true. Most patients, oh no, not C, sorry. Anyway, most patients, that's fine. Most patients will want to be told the whole truth, but there are some exceptions. First of all, every patient is different, okay? So that's important to keep in mind. The quote-unquote whole truth also does not have to be told all at once. Most patients initially are not even aware of how much they want to be told. In some cultures, it may be inappropriate to convey medical facts directly to the patient. So that's actually a consideration I did not even think of. Culturally, it even may not be appropriate. It is useful to encourage patients to ask questions and to tailor your responses to meet their needs. So that's kind of interesting. You're encouraging them to ask questions to determine what information do they need to know. Open-ended questions would be helpful, such as, how much technical detail about your condition would you like me to share? And how much technical information about your condition would you like me to share with you now? Okay, so that's pretty much it. Any questions on that? Let me actually go back to our acronym. You guys think we're on knowledge right now?
Yes.
Okay.
Yes.
Sounds good.
Yeah.
All right, moving on. Number 7. Okay, this is important. There are 2 languages that physicians use in talking to patients. There is English and Medispeak. Unfortunately, patients usually only understand English. Well, actually, in my organization, patients usually understand only Spanish, actually. So that's actually more common. But I think the point is that there's lay terms and there's medical speak. So, excuse me, which of the following is an example of medical speak or metaspeak? So which words is an example of medical speak? Lesion, malignancy, tumor, cancer, or leukemia? Which one is medical terminology or medical speak?
A, lesion.
B.
B. One vote for A, one vote for B. What do you guys think?
Excuse me, Dr. Murad, I didn't get it. Speak medical term?
Yeah, like using medical terminology that patients may not understand.
May not understand?
Yes, that they may not understand.
Okay, okay. So yeah, I think malignancy.
Malignancy, okay. So did everyone vote? Who didn't vote?
I'll go with B too.
B, okay.
Yeah.
Okay, great. Okay, did everybody vote? Was it 3 for B, 1 for A? Was that it?
Yeah.
Okay. Okay, let me see. Let's see. By the way, Dr. Abir, is El Sheikh, is it a common last name in Sudan?
Yeah.
Yeah, actually, I had a classmate from
Pakistan
Sudan.
too.
Was that? I had a classmate from Sudan. His last name was El Sheikh, actually. Yeah. He spelled it Elshieikh, I believe.
It's so common in my country, yeah.
Yeah.
Yeah,
I've been trying to reach out to him. I can't get a hold of him. I hope he's okay. Okay, so let me think. Lesion. You know, when I think about this, I think about what do I see on TV, you know? And I don't see the word lesion on TV. Malignancy, I feel like patients know I feel like I have seen patients articulate the difference between malignant and benign. So that's why for me, if I don't know if malignancy is it or not, but I would rank lesion over malignancy because I feel like I've seen the word malignant out there. I mean, people use that word, malignant. I mean, that's a word that people use in other situations, not just medical. So I feel like lesion, I don't see people say that word. So I would say I would rank A over B. I mean, I don't know, but I would rank A over B because I've never seen anyone say the word lesion. Tumor, I feel like I've seen people say the word tumor. Cancer, everybody knows cancer. Leukemia, yeah, I feel like I have seen I've seen people. Yeah, I feel like people have heard the word leukemia, and people have said the word leukemia. For me, I feel like lesion is probably, if I had to rank them, I've just never seen, I feel like I've seen patients say leukemia, definitely cancer, definitely tumor, and I feel like I've seen them say malignancy. So I feel like if I had to rank them in terms of which is probably right, I feel like A, then B, and C, D, and E to me are all the same, I think. Anyway, so that's how I'm thinking about it. So for that reason, I would probably go with A. By the way, speaking of leukemia, this was an early mistake I made when I was in residency training. If we go back to the acronym, here, sitting is very important. I completely agree. You know, when I was in residency, this was an early example of bad news. My goodness, I'm remembering all these situations now. So when I was in residency, I remember there was a kid admitted to the hospital, and when looking at her CBC, it was clearly leukemia, clearly. So I remember discussing it with the mom, and this was like late at night. She was just admitted to the hospital, and you know, when I was talking to the mom, I was standing, I was not sitting. And I wish I sat. And even before today's topic, long time ago, I regretted that, actually. I regretted not sitting. And, you know, we talked about it, and it was okay, but I think sitting would have been more professional. You know, by standing, it truly showed, wow, this guy must be just in training or something. You know, it showed that I was not expert at delivering bad news. So that's something that I remember. I wish I sat down. Actually, I was with a resident maybe like a year ago, and she was delivering some bad news in the hospital to someone who had liver cancer, okay? And I remember she was standing when she did it. So that was an opportunity, you know, to discuss that we should probably be sitting down when we're saying these things. I think what happens when you're in residency, you're pressured for time, and you're pressured to just move on because you need to finish all your stuff, right? And I think that plays into it sometimes, where you may forget to do these things, which you know, if you think about it, it's common sense. But yeah, I think especially for residents or students or people in training, it's a part of the training for delivering bad news is you should be sitting down. So I wish I did that. So that's when we're talking about leukemia, I remembered that. So anyway, are you guys ready to see the answer?
Yes.
Yes.
By the way, we're only halfway done the questions. I think we need to speed it up, huh? So let me see. Let's see. It is number 7 is A, indeed. So most healthcare professionals unconsciously use their own professional jargon. Using Medispeak to explain something to a patient makes it less likely that the patient will be able to ask relevant questions. It also tends to isolate and alienate patients who find it unfamiliar. A comparison of examples is listed here. Other examples, there are other examples. So leukemia, that is something that is non-medical people will say. Cancer, non-medical people will say that. Now, multiple sclerosis apparently is another one. I can, there's some other examples here. Multiple sclerosis is okay. Okay. So that's okay. Now, bad terms, like you don't want to say blast cells. Blast cells, they don't know. So this is bad. Hold on. Blast cells is bad. Demyelination. Is bad. So you can say multiple sclerosis, but you don't want to say demyelination. You can say leukemia, but you don't want to say blast cells. Okay? Space occupying lesion. Bad. Okay? So you can say tumor, but you don't want to say space occupying lesion. Okay? What else? Oh yeah. Prognosis is guarded. That's bad. You don't want to say that. Instead, you can say the situation is serious. That's okay. All right. So, for me, one of the things I do in the office is colposcopy procedures. You guys know what a colposcopy is?
No, I don't know.
So
biopsy of cervical.
Yeah,
Yeah,
it is
Biopsy of endocervical.
it is endoscopy, like to visualize the cervix.
correct. Yes.
Scope,
So
it is scope, yeah.
yes, with colposcopy, we use it to visualize the cervix and to take biopsies of the cervix. So this is something that I routinely do in the office. Now, this is not delivering bad news, but when I consent the patient, for a colposcopy, I'm very particular about this, very particular. So I try to use common words and to try and avoid medical jargon. Because in a colposcopy, when I'm consenting patients, they're usually very anxious and nervous, and they don't know a lot of things. So when I use medical terminology, they get very uncomfortable. They don't know what questions to ask, and they remain very anxious and scared. So examples of what I do when I'm consenting them for the colposcopy is I talk about their pap smear. So when I talk about their pap smear, I don't say high-grade lesion, low-grade lesion. I don't say that. I say the pap smear was mildly abnormal or moderately abnormal. Abnormal, they understand. Mild, moderate, if I say severely abnormal, they understand mild, moderate, severe. So they understand those words. So I say your pap smear was mildly abnormal. I don't say your pap smear showed LGSIL or low-grade intraepithelial lesion. You see? So that's an example. There are many things actually. There are many, even the word procedure, because a colposcopy is a procedure. To be honest, a lot of times what I'll do is I'll say, that's not medical speak. I mean, procedure people understand. That's English. But even that, I will say I'll use a different word because the word procedure can get people anxious. So I pick my words very carefully. Oh, and then if I say the word cancer, I'm very careful when I say the word cancer, because when I say the word cancer, if I don't use it right, then patients, they stop listening to me. They shut down. So anyway, the words that you use are very important. So part of using the words correctly is to use English and not medical speak, so that you can get the patient to calm down, get them to ask questions, basically. So any questions on that? So
No.
very good. Okay, moving on. Number 8. Which of the following statements is false regarding the involvement of family physicians in the care of a patient with cancer? Is it A, ideally the family physician should be present when the patient is informed of a bad diagnosis or prognosis? Is it B, the family physician and the primary consultant, I assume the specialist, should be in contact and should be certain that the same message is delivered? Or is it C, family physicians have a limited role to play once the patient is enrolled in a tertiary care cancer center treatment center? Or is it D, the family physician has a responsibility to follow up on the care of his or her patients regardless of whether he or she is actively involved in all aspects of care? Or is it E, the cancer becomes as cancer becomes a more chronic rather than fatal condition, much of the long-term care can be managed by the family physician? Which statement here is false? So remember, it's not which one is the good one, it's which one is the bad one. So keep that in mind. Why don't you guys think about that? I'm here in the office. I'm going to step out and do something real quick. I'll be back in 2 minutes. Guys, take a look at that, and when I come back, we'll go through our answers, okay?
Sure.
All right, guys. Okay, that was ample time, I believe. What answer would you guys give?
I'm going with B.
B, okay, that's Dr. Sameh. Okay, Dr. Abir, what would you say?
Between A and C.
Okay, you have to pick one. What would you say? You got to rank one over the other.
I think A.
A, okay.
I'm going with A too.
A. Okay. Okay, it sounds like we have 3 for A, 1 for, was it D? Or sorry guys, what were those answers again? One more time.
I said A.
A.
I said A.
Okay, 2 for
Me
A,
too.
3 for A. And what was the last one?
Sama. I think Sama said E.
Oh, Dr. Sameh said E. Dr. Sameh, is that right?
Yeah, I think so.
No, not E, B both.
Ah,
Oh, B. Okay, very good. Okay, so 3 for A, 1 for B. Okay, let me see. All right, ideal. So, okay, now remember which one is false. So you're not looking for the right one, you're looking for the wrong one, right? So let's see. Ideally, the family physician should be present when the patient is informed of a bad
Oh,
diagnosis.
sorry, Dr. Murad. Sorry, it's a false.
Yes.
Uh,
You guys want to change your answers?
yeah, 1 second.
Okay.
Okay, maybe I'm going with D, doc.
D for dog, okay. Okay. You guys agree with D?
No.
What would you say? So it looks like this is a tough one, huh?
I think the family physician follow the patient throughout the course of his or her condition.
Mm-hmm.
So I think the option D is correct.
D is correct. Okay. So remember, we're looking for the false, right?
Yeah.
So if you think something is correct, then that's not. I believe that's not your answer, correct?
Yeah, my answer was A.
Oh, you're A. Got it. Okay. Okay, guys. I will see. So what's the final verdict? Abir, what was your final verdict?
A.
A. Dr. Chowdhury, you said A, I think.
Yeah.
Okay, Dr. Sameh?
I said
Sama.
D.
Dr. Sameh said B.
D.
D.
D, doc.
Okay. Okay. Wow. Okay. So that's lots of opinions on this one. So let's see. So I'll take a shot at it. So which one is false? So this is the topic here is follow-up. So a patient, now this is after a patient is diagnosed with cancer, what is the role of the family physician at that point? So ideally, the family physician, oh my goodness, excuse me, should be present when the patient is informed of a bad diagnosis or prognosis. That sounds about right, that sounds about true, because as family physicians, what I know is that we should be involved with our patients. We take care of the whole patient. We coordinate the care of the patient. As a family physician, I'm not really aware of a situation where we're just supposed to check out, So, so to be present at the time when the patient is informed of a bad, hopefully the family physician is delivering the diagnosis, so A sounds about right. So I have that kind of lower as an answer for this. B, The family physician and the primary consultant should be in contact and should be certain that the same message is delivered. That sounds good to me. There's nothing seems wrong with that answer. I would agree that it should be the same message delivered, and there should be communication between the specialist and the family physician. I mean, that all sounds appropriate. So B is not high on my list as an answer for this. C, the family physicians have a limited role to play once the patient is enrolled in a tertiary care cancer treatment center. So here's the thing. I think in practice, yeah, that happens a lot. I do think that. And I think sometimes the systems that are set up in offices may make this a challenge, to be honest. And so I wouldn't blame people, or I wouldn't blame colleagues if maybe their role is limited when the patient is enrolled in a tertiary care center. I think that does happen a lot. And there are barriers. I think ideally, as a family physician, we should have more of an active role to play. And there's even a patient I'm thinking of where I think there was probably an opportunity where I could have had more of an active role, to be honest. And so I think C, maybe in reality that happens, but ideally, as the family physician who helps to take care of the whole patient and to coordinate care, that maybe that shouldn't be the case. So C, I would rank above A and B as the answer. Now D, the family physician has a responsibility to follow up. I mean, anytime an answer starts off with this, it's probably true. I mean, the family physician always has the responsibility to follow up. So anyway, to follow up on care of his or her patients, regardless of whether he or she is actively involved in all aspects of care. So what's interesting is that D and C cannot both be true. So if D and C cannot both be true, one of them is the answer, okay? That's another way of how to think about this. So even if you don't know what's correct, you see what I mean? Even if you don't know what's correct, they can't both be true. So it's one of them. Now E, as cancer becomes a more chronic rather than fatal condition, much of the long-term care can be managed by the family physician. And I believe that's true not just of cancer, but for a lot of conditions. HIV, for example, is another condition which is becoming more of a chronic disease. And the family physician has a lot of things to do when it comes to someone living with HIV because of that patient's, like, they have a lot of their primary care needs are even more important. So it's not just with cancer. So I feel like that's true. I feel like that HIV, even if I don't know the answer here, I know that that's true of family physicians with HIV, for example, taking care of HIV patients. So E does not strike me as the most likely to be false. So having said all that, I feel like probably the answer is C. Okay. Guys, ready? Number 8. Yes, the answer is C. So, family physicians assume and maintain a coordinating role in the care of patients with cancer. Although at a certain time, a patient may be receiving treatment in a tertiary care treatment center, the family physician must be seen as coordinating the care. Communication between the family physician and the family and the specialists involved should be maintained. Much of the long-term care can be managed by the family physician as cancer becomes a more chronic rather than fatal condition. The family physician's role can be described in terms of the 5 C's. Oh, wow, we have another acronym. Hold on. The 5 C's. Let me do this. Hold on. Actually, let me bring this down here. Bear with me. Okay, let's see what these 5 C's are. Okay, it needs to be, the family physician's care needs to be continuous. It needs to be comprehensive. It needs to be compassionate. It needs to be coordinated. And it needs to, excuse me, competent. Okay. So these are concepts that describe the family physician's role in the, in, really overall, just in general, and here in patients with cancer. So, okay, any questions about that? Nope.
No.
Okay. All right, let's move on. Which of the following is or are true regarding the delivery of bad news to a patient with to patients with a serious disease? Is it A, check the patient's reaction to the situation frequently? B, reinforce and clarify the information you are giving? C, check the patient's understanding of the facts? D, elicit the patient's concerns? Or E, all of the above are true? What would you guys say?
All of the above are true. E. I'll go with E.
E. Guys agree?
Yeah, agree.
Yes.
Okay. Yeah, I would agree too. So I would say E. Let's see what the answer is in this case. Okay, fortunately the answer indeed is E. Let's check out the information. So while providing information to the patient, it is imperative that the physician keep all of the following principles in mind, which we have talked about. First, provide the information in small chunks after firing the warning shot. So we talked about the warning shot, and we talked about how the warning shot can be done while sitting. The other is use English and not medical speak. Then check the patient's reaction in terms of both information processing and their emotional state. So you see how are they responding? Are they understanding? What's their emotional status? You want to reinforce and clarify information that you are giving. You want to also elicit and address the patient's concerns. And then you adjust your agenda to the patient's agenda. So these are all principles to keep in mind. So any questions on that?
No, it's clear.
Okay. All right, you guys, we're almost done. So next question. In an interview in which news of a serious disease is presented, which of the following is the thing to do before the patient leaves the office? Is it A, make sure the patient understands every word? B, make sure the patient understands that you are doing everything you can? C, make sure you leave the office with a follow-up plan and provide the patient with some hope? Is it D, make sure the patient understands the dismal prognosis? Or is it E, make sure that you have left no question unanswered? This is an interesting one. What would you say? I don't know the answer for certain either, but, oh, sorry, Dr. Abir, what's that?
I'll go with E.
Okay, so Dr. Chowdhury goes with E. Okay, what else do you guys say?
It's E too.
Like E, good. Anything else? Yeah, we have 2 for E.
I think more than one answer is correct, or what, we have to choose one answer.
Yeah, so this is the thing about multiple choice questions is that in this case, it looks like only there is one best answer. So, you know, when I approach these questions, I just tell myself, you know what? I don't know the answer. I really don't. I'm not sure. I don't know. And if I knew it, great. But if I don't know, I don't know. But remember, the question is, what do you know? You know something, right? So use what you know to help determine the most likely correct answer. So almost rank them in your head. So if you can narrow it down between a couple, which one is more likely than the other to be correct, right? Based on what you know. So we had 2 for E.
I'm going with E also.
Okay.
I go for D.
All right. 3 for E, 1 for D. All right. Let's take a look. So let me give it a shot. So make sure the patient understands every word. Well, I don't know if that's practical. I don't know if that's practical. So that one I'm suspicious of. So I'm going to put a pin in that. B, make sure the patient understands that you are doing everything you can. I think that sounds, on its face, it sounds reasonable. You would like the patient to, know that you're doing everything you can. But when I look at the question, it says, which of the following is the thing to do before the patient leaves the office? Certainly you want to reassure them that you're doing everything you can. But the way I picture it in my mind happening is the patient leaves, before the patient leaves, you say, now listen, I want you to know I am doing everything I can. And yeah, I'm not sure about that necessarily. There are probably other things you want to emphasize. If I have to rank A and B, I would probably do B over A, to be honest. Like I would pick B over A. So that's my ranking so far. So let me look at now C. So I'm putting pins in both of them with B probably above A. C, make sure you leave the patient with a follow-up plan and provide the patient with some hope. Now, I agree that a follow-up plan is very critical. It's very critical. And you provide the patient with some hope. I think that that's very appropriate if you can. I think the only thing I worry about with this one is that we don't know what what diagnosis are we talking about here? If I go back.
It's a serious one here in the question.
Yeah, where is it? Here. It's adenocarcinoma. Yeah. So we don't know how much hope there is.
And we cannot give patient the false hope that everything is going to be okay when we are not sure.
Exactly. And when I come up here, there was one answer that said, tell the patient not to worry about it. Where was that? Yeah, here. The first step in breaking bad news, tell the patient not to worry. Well, we don't want to do that either. It's not the same thing. It's not giving them false hope, but yeah, that's a temptation. Like it's a temptation for sometimes actually. You want to avoid that temptation. Oh, don't worry about this. You don't want to stress the patient out unnecessarily, but I mean, you want to do everything you can to present things in a way that the patient can absorb and understand and to take it in the best way. But to tell the patient not, actually, to be honest, when you tell the patient not to worry, they get more stressed out, to be honest. Anyway, that was what it reminded me of. But going back to here, give them some hope. I think, yes, you give them hope in appropriate situations, but without more information, I'm not sure about this. I think with some hope, I think you need more information to be more comfortable with this part. like on its face, it sounds good. So I don't know, A, I think has dropped off for me. B and C are kind of there. I'd put a pin in it. D, make sure the patient understands the dismal prognosis. Yeah, sort of the same thing. Without more information to say that, oh, you have a lot of hope, or this prognosis is dismal. Yeah, without more information, I would be hesitant to say that. And also, the way I see it happening in my mind is when a patient leaves, it's like, I want you to understand this is a horrible diagnosis. I mean, are you really going to say that? You know? So it doesn't feel like something I would do. So sometimes what helps me is to visualize, how does this happen in real life, you know? So here it says, before the patient leaves the office, what do you want to, you know, what is the thing to do before the patient leaves the office? You know, to tell them, oh yeah, I just want you to know, make sure you understand this is a horrible diagnosis. I just don't know about that. So D for me, I have B and C kind of above D. And then E, make sure you have left no question unanswered. That to me is probably right, actually. So for me, when I visualize this in the office, I'm like, what questions can I answer for you? You know, what can I answer for you? And then you want to say, whenever you do that, you want to say, do you have any other, especially if there's something serious. If it's something like not serious, maybe it's, you could possibly you can approach it a little differently. But if this is very serious, it's very appropriate to say, and to be honest, even if it's not serious, but it's very appropriate to say, what other questions do you have for me? Okay, because you're going to need to spend time with this patient, with this diagnosis. So what other questions do you have? If a patient has a question, and you're like, okay, time's up, I got to go. Well, what is this? That doesn't sound right, you know? So to leave, when the patient still has questions, to leave without adequately answering them, there's something wrong with that. So for me, I think there's like, I like C, to be honest. I like C, you know. B feels kind of quirky to me. It's like, it's sort of, you're making it about you. You're making it about you, the doctor. Like, I want you to know I'm doing everything I can. It's like, okay. There might be some other questions to answer. So for me, I actually like B. A is kind of lower. I like C better than B. D seems kind of weird to me. So for me, it's lower. E, like if I like C, I like, E, I like, but there's a greater risk with C because of this with some hope, because it's like, you might want more information. So while I like C, there's just a chance that there's an issue with this. E, like, is more solid. Like, there's like, you don't need more information to say that E is right, you know? So for that reason, I probably go with E. Sound good? Let's see. Let me pull up the information here. So this is what, number 10? Oh my God, you guys, it's C. Look at this. I guess you have to ignore everything I said.
Yes.
I was just sharing my thought process. You guys, it is C. Let's look at this, shall we? Man, I like C too. That's too bad. Let's see. All right, Tennessee. Let's see why, shall we? Who, by the way, who said C here? Did anybody say C?
No.
Ah, nobody said C.
Unfortunately.
Nobody got it. Wow. Okay, let's take a look. Okay. Now, make sure before the patient leaves your office that you provide him or her with a follow-up plan. Okay? This will reinforce the belief that you are indeed in charge of his or her care, and you will ensure that the care plan is implemented. In addition, be sure to leave the patient with some hope for the future. Okay. That hope must be realistic, but it must be hope nevertheless. Okay? So that's how we were supposed to think about it. What do you guys think?
I think they should add realistic in the question so we can pick it easily.
Yeah. So
Because we don't want the patient, false reassurance or false hope.
Sorry, Dr. Abir, I interrupted you a few times. I apologize. Can you say that again?
I said, this question, they should add the realistic hope because we don't want to give the patient false reassurance or hope if there is no. Because they, in the stem of the question, they said serious disease. It could be terminal, it could be disseminated cancer.
Yeah, I guess with, and maybe what they said, maybe when they said here, some hope, maybe that should have been a clue for us to think, okay, well, then they're asking us, that when they say some hope, they're implying that the hope should be realistic. You know what I mean? Maybe that's what they meant when they said some hope in this wording. So, yeah. So this is a lesson to us too. It's a lesson to us that, for the well-being of the patient, sometimes knowledge of epidemiology can be helpful in giving, a prognosis. You can say, this is the prognosis and this is the chance of survival. So it's not zero, something like that. What do you guys think?
Yeah, that makes sense.
Yeah. So it's interesting, going back to E, making sure that you left no question unanswered. So maybe in retrospect, looking at this answer, maybe that's a little too much, maybe it's an unrealistic expectation to say, well, I need to make sure I have every last question answered. Maybe that's an unrealistic expectation. It's important to try, but maybe that's a little, maybe the wording is a little too strong for that, possibly, in retrospect. So, okay, guys, good. Any other questions with this one? We're ready to move on.
Yeah.
Let's move on. There's only two more, so. Okay, guys. So this one. So when Joanne, a 14-year-old, was diagnosed with leukemia, her mother asked you what Joanne should be told and by whom. How should you reply? Is it A, Joanne should be told she has mononucleosis and will feel very fatigued for a while, but she will ultimately be cured? Is it B, Joanne should be told by the physician that she has cancer and may die of it, but if she survives the treatments, she may also be cured of the disease? Okay. C, Joanne and her parents should hear the diagnosis from the physician together, including the name, a reasonable description of the treatment, and the hope for a cure as the outcome. Or is it D, Joanne should be told she is too young to worry about a diagnosis, and her parents and the physician will take care of it? Or is it E, Joanne's parents should tell her whatever amount they are comfortable with and be the conduit for any questions that she might have about diagnosis and treatment? My aunts in Egypt, I think probably most of you guys understand Arabic. So khalti, basically, khalti. She's in Egypt, and she was diagnosed with ovarian cancer. Okay, and when you're overseas and you're trying to get information about someone who is sick, it's very hard when relatives in Egypt are sick, because you can't get anything reliable. So then we ask about her, how's she doing? And say, oh yeah, the doctor says she's doing fine. And then you look at some of the information about the diagnosis, it's like, doing fine. yeah, this is like terminal. What do you mean doing fine? Like I was able to, because, sometimes family, they give you medical records to look at and things. And she's not fine. Like she has ascites. She has metastasis. It's like, no, she's not fine. But it's interesting because she's told she's fine. So this is a very interesting situation where cultures, in different parts of the world, when it comes to breaking bad news, they don't, it's not the same like it is in the United States. So that's something, especially if you guys are international medical graduates, to be very familiar, to be very aware of, basically. So anyway, do you guys have any similar stories of family members, they're not told the bad news?
Yeah, it is common in our culture too.
Yeah. I'm not sure. Now, having said that, you can give it the benefit of the doubt. So Dr. Abir, that was you who said that, right?
Yes.
So why don't you share, Dr. Abir, what you think? This is a different approach, the ethical guidelines are a little bit different. So do you feel that is appropriate that's appropriate for the patient and the family? Do you feel like outcomes are better this way? It's possible it may be because it's a different setting. Like, what do you think? Do you feel like the way it's done is better, or do you feel like what we're going over now, that should be adopted there? Like, what do you think? By the way, Abir, you're from Sudan, right? That's right.
Yes,
so,
yes.
Yeah. So what do you think when you compare these differing approaches?
In my opinion, I think the patient has a right to know everything about his disease.
So it sounds like you feel that this approach that we're discussing now, it'd probably be better if it was adopted in Sudan, for example.
Yes. And we don't have to listen to the family member, like hide this from the patient, don't tell the patient the truth. I think it's against the right of the patient. But to be honest, we do that all the time in our country because there is no restrict guidelines. There is no restrict rules like here in America. But I think it is better to share everything with the patient.
Yeah.
We can deliver that according to the patient knowledge, according to his education. So we can modify how to tell the patient, but at the end we have to inform the patient about anything.
Right. Absolutely. Yeah. What about you, other guys? Do you guys agree, or do you feel like do you agree with Dr. Abir or disagree?
Basically, I'm agree with Dr. Abir.
Yeah.
But the idea behind that, I think, because in Sudan we have very, very, very good family communications. So basically, for me, if my father know my diagnosis or my mother, just pay, because I'm sure that they will support me at that situation. So yeah, in my country, there is no disclosure from the family members. Even if I have full knowledge and I know everything, this is not the thing. But basically, the main thing that they know that the family will be supportive.
Right.
Yeah.
Yeah, I agree with you, Samah, but we discuss about the family knows that they know the diagnosis, but the patient not. They hide that from the patient.
Yeah, I agree with you, Abir. I said this not because the ethical guidelines just, but because in our community, there is very strong family communications, right?
Yeah, they support.
If at one point the patient that knows that the condition hide it from him and his family members know the condition, he will not be upset, right?
Yeah,
he will
but
not
I
be
think
upset, yeah, and he said that, yeah, why you didn't tell me? Because he knows that his family knows the best for him, and there is very good communications, basically.
And in my country, we try to let patient know about the diagnosis and prognosis. Like, we have to be honest with the patient, just like in US. We cannot hide the things from the patient, and we let the patient know the amount of information he or she wants to know.
I see.
Yeah, I have heard that in one story, the patient diagnosed with coronary artery disease, and her son hid the diagnosis from his mother. And for many years, the mother took medication, but she didn't know why this medication. Every time the son said it is for infection, it is for a cold or something like that. And one day the patient went to a family doctor, and the doctor asked her, "How long have you been taking this cardiac medication?" And the patient shocked, and she fainted in front of the doctor and blamed her son why they hide the diagnosis from the patient.
Yeah.
So I think the patient should be informed about the diagnosis and prognosis as well.
Yeah, it's interesting. I think, like, you guys are saying pretty much the same thing. Like, you know, the patient has a right, the patient should know. And I think Dr. Samah was mentioning the point that maybe what has contributed to the current approaches in a lot of in different parts of the world is that because the family network is so strong, you know, and it's always been so strong, maybe much stronger than the United States. That's why it's been acceptable to just do what the family wanted, to share or not share with the patient, because those family units are acknowledged as like, you know, because it's the patient's like primary like support, and the family network is so much stronger than in like the US or other countries, that it's fine to go ahead, like it's acceptable to go ahead to listen to the family, to not share a diagnosis. So Dr. Samah, it sounds like, was sharing why that developed to be the case, and that's the difference between the U.S. and other places, is that other places the family unit is, you know, so much stronger. So that's very interesting. And you know, my wife, her uncle had a daughter, and she had a congenital heart condition. Never told the daughter, never told her. And can you guess what happened?
No, I want to hear that.
So she had a congenital heart condition, and he would always do whatever she wants. Again, I think you guys know Arabic. Sorry, Dr. Chowdhury, you may not know Arabic. I'm so sorry. When I was talking earlier, khalti means my mother's sister, basically. My aunt's on my mother's side.
Okay.
Yeah. Sorry, Dr. Chowdhury. My goodness, I have to be
no
careful.
problem.
So, anyway, what was I? So anyway, so he did not tell her daughter at all that she had a congenital heart condition, and she died. Actually, she collapsed one day and she died. Very interesting case, isn't it? You know, this is a minor. The dad made a decision never to tell her. And who knows, maybe, you know, it was amenable to surgery, for example. You know? Yeah, it's very interesting. So
we'd like to hear your perspective in this issue. Do you want to?
Oh,
do you agree with me, or?
Well, I think let's try to answer the question. So what do you guys, I think it's been a long time since we looked at the answers. So what do you guys think is the answer to number 11?
I'll go with option C.
Yeah, me too.
C, okay, good. We have 2 for C. Anybody else?
Yeah, I'm for C also.
Between C and E, but I'm going to C now.
Go with C. Okay, let me take a shot at it. Joanne should be told she has, well, this is, A is just lying to her. I don't think that's really acceptable. So I wouldn't go with A. B, Joanne should be told by the physician that she has cancer. She may die of it, but if she survives the treatment, she may also be cured of the disease. Okay, I think that's better than A, but I don't think that's ideal. It may be a lot for a 14-year-old. But if I have to pick between A and B, I guess I would go with B. Let's go with C. Look at C. Joanne and her parents should hear the diagnosis from the physician together, including the name, a reasonable description of the treatment, and the hope for a cure as the outcome. This seems very consistent with what we've been talking about. So I like C better than B. So far C is the best one. Let's look at D. Joanne should be told she is too young to worry about a diagnosis. Okay, right away, that sounds weird. You would never tell, I don't know in what situation you can tell a pediatric patient, you're too young to worry about it, So what does it say? You're too young to worry about it, and her parents and the physician will take care of it. I mean, there's potentially just multiple things wrong with this. It just doesn't sound like an appropriate thing to tell a pediatric patient. And to say her parents and the physician will take care of it. Well, maybe you can't take care of it. If you're the family physician, maybe you have to refer to a specialist. I mean, you're going to tell her that. And her parents will take care of it. Maybe her parents don't want you to tell her that, And then you're giving her, we'll take care of it. So you may be offering false hope, possibly, right? Whereas in C, it says, and the hope for a cure. In other words, it sounds like you're going to give realistic. And it's better than B, because B says you might die. I mean, come on. You're gonna tell that to a 14-year-old. So anyway, yeah, D I think just has multiple things. So let's go to E. So far I like C as the best. Let's look at E. What did you guys pick, by the way?
I picked C.
Okay, you guys picked C. Okay. Let's look at E. Joanne's parents should tell her whatever amounts they are comfortable with. Oh, this may be reasonable. Let's see. Joanne's parents should tell her whatever they are comfortable with and be the conduit for any questions that she might have about diagnosis or treatment. Actually, it's interesting. This is like Egypt.
I'm thinking about it.
Yeah, this is like our countries back home. Not Pakistan though. It sounds like Pakistan has more, is not quite the same. But yeah, Joanne's parents should be told whatever amount they are comfortable with. Or Joanne's parents should tell her whatever amount they are comfortable with. It's actually interesting. I don't know. Joanne's parents should tell the patient whatever amount that the patients are that the parents are comfortable with. I don't know. It doesn't sound so unreasonable. But I guess the thing that sounds weird is, and be the conduit for any questions that she might have. So the parents are wanting to be, like we said, like it's a back home, right?
Yes.
Yeah, because that's what the family is like. They're like, I'll be the conduit. Or it's just like the dad who did not tell her child. Actually, parents, if parents don't, in certain situations, if parents do not bring timely medical care to their kids, they can get in big legal trouble. So like in the case of the dad where his child had the congenital anomaly, he was the conduit. Or it's just like in that situation with the cardiac medication. Whose story was that?
Yeah, my story.
Yeah. And this can be problematic. Like look at what happened to Abir with your case. She went to another physician and the physician said, what's going on? Like gave her shocking information. Yani, is this a way to get bad news? She fainted, right?
Yes.
That's not, so this by itself is bad outcome for getting bad news, So, there can be problems when the parents say, no, I'll only be the one. So, I mean, it sounds sort of reasonable, like, We'll tell her what we're comfortable with. We'll be the conduit for any questions. Like on its face, it doesn't seem so unreasonable, I guess, but there might be some problems. So C sounds more collaborative. You're there with the family, so the family can, like consistent with previous situations, they can be the communication aid for talking to this minor, this pediatric patient. So yeah, I think for these reasons, I like C better than E. So I'll go with C. Okay, let's see what the answer is. This is number what, 11? Okay, the answer is C. Okay, let's see what the situation is here. Okay, you guys ready to hear the facts? All right.
Yes.
So there is weak evidence that communicating information to young parents, interestingly, I didn't know they were young parents. There is weak evidence that communicating information to young parents about the diagnosis and expected tests and interventions may help children and their families better understand, prepare for, and cope with their illness, the medical or surgical procedures they may undergo, the discharge from hospital and return to school and community, any relapses that may occur, and in some cases, their last weeks of life. Interventions that offer opportunities for children and adolescents with cancer to communicate their experience of their illness and treatment may be helpful to them. What do you guys think of that information? So I misread it. Now I see why I misread it. Sorry. I apologize. Not young parents, young patients. Let me read that again. I'm sorry. There is weak evidence that communicating information to young patients about the diagnosis and expected tests and interventions may help the children and their families better understand, prepare for, cope with the illness, medical surgical procedures, discharge from hospital and return to school and community, any relapses, and possibly last weeks of life. Okay, so there's weak evidence that communicating directly with young patients facilitates better outcomes. So that's basically it, I think. What do you guys think? Sound good?
Yes.
Okay, all right. I want to say this is our longest session ever, by the way. Usually our sessions are done in 2 hours, so I apologize. I hope I'm not interfering with everyone's schedule, so I do apologize. Clinical case 3. What was that?
I said it's fine. It's an interesting session.
Well, this is our last. This is well, good. I'm glad. So here's the case. One more question and we're done. Okay. Life after the bad news. This is a very interesting one, actually. So a physician diagnosed with a terminal illness returns to his home university to continue the pursuit of his academic career to the best of his ability after having received bad news about his medical condition. He purposefully does not tell his colleagues the truth about his disease and continues to teach and write and receive grants and publish and practice medicine. His condition deteriorates and he becomes increasingly more physically disabled. Okay? Last question. Which of the following scenarios is or most likely to occur? Is it A, he is likely to receive more phone calls from concerned colleagues and more inquiries as to whether they can be of assistance to him? B, when his colleagues see him in the hall, they will go out of their way to talk to him and offer any assistance they can. Is it C, once his colleagues are aware of the full extent of his illness, they will offer not only moral support, but also support in terms of assistance with teaching, assistance with looking after his patients, and assistance in keeping his research programs viable? Is it D, all of the above are likely to occur? Or is it E, none of the above are likely to occur? What do you think?
I think all of them,
Okay.
all of the above could be care.
Okay.
I'll go with D2 because I think all of the above are likely to occur.
Yeah, me too.
Me too.
Okay. Let me take a shot at this. He is likely to receive more phone calls from concerned colleagues and more inquiries of whether they can be assistant. Yeah, I think that's probably true. I think that's probably true. You're likely to receive more phone calls. When his colleagues see him in the hall, they will go out of their way to talk to him and offer any assistance they can. Yeah. I think offer any assistance, yeah. They will go out of their way to talk to him. That might be true, but I don't know. Is it always true? Can't say for sure. I want to say if they're family physicians, yeah, family physicians are nice. So, we are talking about, colleagues here. So, okay. So I'm not sure. C, once his colleagues are aware of the full extent of his illness, they will offer not only moral support, but also support in terms of teaching, assistance looking after his patients, and assistance in keeping his research programs viable. Yeah, boy, they're really helpful colleagues, I have to say. Offer assistance in keeping his research programs viable. That could be. I mean, so basically we have colleagues that are just going all out of their way, going above, offering all types of assistance. So basically A, B, and C in my mind are all kind of saying the same thing. So either all of the above are true or none of the above are true, basically. Yeah. So which one is it? Is it all, or so it's really down between these two. Which one is more likely to be correct? Let me think. So is it more likely that your colleagues are going to go above and beyond and to help with your teaching and help with looking after your patients? And maybe because, I work in administration more so nowadays. So maybe I'm just used to seeing the bad side of people. I don't know. Yeah, maybe I'm biased. Because it's like they'll go above and beyond to help with teaching and your patients and your research. I don't know. I mean, it might be. Once when they're aware of the full extent of his illness. You know what? I'm going to go out on a limb here. I'm going to go out on a limb and I'm going to say none of the above. You guys may very well be correct. You may very well be correct. But I feel like they're just everyone is going above and beyond to help and things like that. And I just don't know. I don't know the answer. I do not know the answer to this. But I feel like I have enough doubt where I feel like I will pick E because I just have some doubts about it. So I'll go with E. Okay, but you guys may very well be right. I don't know, but that's how I'm thinking. You guys ready to see the answer?
Yeah.
Yeah.
Okay, we'll see. I think this is the first one. This is the first one where you guys all picked one and I picked a different one. So we'll see, right? Usually there's strength in numbers, so there's a good chance you'll be right, but let's see. All right, last one. Woo, I got it. It's E. This doesn't happen usually. So, okay. Oh my God, you guys, I can't believe it. So the answer here is very long, you guys. I'll just try and go through it, okay?
Okay.
All right. So this is very interesting. Actually, there's a story behind this apparently. So E, By the way, I work in administration now more, so part of my responsibility is to oversee other providers, and you get used to seeing the bad side of people. So I just, when it says, oh, everyone is going to go above and beyond to help, I'm like, yeah, I just don't know about that. But let me just see. Okay, here we go. So apparently, this case is a true story and was told eloquently by a physician named Rabin in the New England Journal of Medicine in 1982. The observations made by both the observations made of both the consultation with the neurologist and the reaction and treatment of the physician-patient, or reaction and treatment that the physician-patient, that's what this is, it's a patient who's also a physician. So that the treatment that the physician-patient received when he returned to his home university have been summarized. And so here is the patient talking. My first reaction to the neurologist was one of deep disappointment from his impersonal manner. The neurologist exhibited no interest in me as a person and did not even make a perfunctory inquiry about my work. So the neurologist did not even know that the patient was a physician. He gave me no guidelines about what I should do, either concretely in terms of daily activities, or what was more important, psychologically, to muster the emotional strength to cope with a progressive degenerative disease. Maybe this is multiple sclerosis or Lou Gehrig's disease or something like that. The reaction of colleagues, interestingly, this is interesting. The reaction of colleagues to another problem is illustrated very well in the following description. So here's the patient in his or her own words. I had not confided in my colleagues, but as time went on, my limp was worse, and I now held a cane in my right hand. The inquiries ceased and were replaced by a very obvious desire to avoid me. When I arrived at work in the morning, I could see from the corner of my eye colleagues changing their pace or stopping in their tracks to spare themselves the embarrassment of bumping into me. As the cane became inadequate and was replaced by a walker, so my isolation from colleagues intensified. One has to ask, this article continues, one has to ask why this happened. The author, who's the patient, suggests, this is his suggestion, it's a he, I think. Perhaps it is because we as physicians are healers. We dispense treatments, counsel, and support, and we represent strength. The dichotomy of being both a doctor and a patient threatens the integrity of the club. To this guild of healers, becoming ill is tantamount to treachery. Furthermore, the sick physician makes us uncomfortable. He reminds us of our own vulnerability and mortality, and this is frightening for those of us who deal with disease every day while arming ourselves with an imaginary cloak of immunity against personal illness. So there's more description in this article. Others would suggest that seeing one of our peers suffering brings an illness too close to home, and individuals would have to deal with their personal reaction to a similar disaster. The author also suggests some simple steps that we can take to support our colleagues, as well as some guidance to other patients who desire to continue their profession in times of illness, stress, trouble, or other difficulty. For the patients, confide the illness and your plan for dealing with it, and let people know what they can do to assist. So this is some suggestions. If you're a physician and a patient, confide your illness and your plan for dealing with it and let people know what they can do to assist and give specifics. Like bring me a meal or provide the lecture on Friday as I have treatment, as I have treatment other times. Greet them, to acknowledge them when you see them. Inquire about their health and visit them. Offer them support if they are physically handicapped. Be conscious of the physician-patient's family and extend support to them. The spouse and children are suffering at least as much as the physician and need support, encouragement, and acknowledgement of their difficulties. Finally, remember that the absence of a magic potion against the disease does not render you impotent. No one can assume the burden, but for the patient, knowing that he or she has not been forgotten does not ease the pain. Or I'm sorry, it does ease the pain. This special type of communication and caring among physicians or any other professional group is essential as we enter an era of change unlike any other era healthcare has ever seen. This is back in 1982. Remember that the word doctor is translated from the Latin doctor, which means teacher. I don't know if you guys knew that, but doctor, the Latin root of doctor is teacher. As physicians, we are all teachers, some in more diverse ways than others. Medical students, residents, patients, other healthcare professionals, and most of all students play the role of the patient at one time or another. So then there's a quote here by Confucius, that famous philosopher that I need to learn more about. So there's a quote that says, when the student is ready, the teacher will appear. So anyway, so that is that. So that's a nice article there about number 12. So what do you guys think about that? Do you guys have any experiences with other colleagues or doctors or any similar situations where they're very sick and ill?
Yeah, as Samah mentioned before, in our country, definitely the answer is gonna be D.
Very interesting. Very interesting. Another cultural difference, it sounds like.
Yes.
Yes, I see. Well, that's very good. Yeah, you see kind of a theme recurring where maybe in other countries, the things are not as systematic, things are not as standardized, and maybe a way of compensating for that is you have closer community ties, closer family ties, it sounds like.
Yes, you are right.
Very interesting, very interesting.
Yeah, I totally agree with Dr. Abir.
Yeah.
Yeah, that's the issue basically. That's why all of us choose number D, because this is our usual behavior. If one colleague in my country have a problem, all the other colleagues will be assistant for him.
Right. Yeah. It's very interesting. It's very interesting. So these are some nuanced differences, I suppose. Good.
When I was doing, I have some work experience in Sudan before. One of my colleagues, her mother was having breast cancer, and she traveled from Sudan to Egypt. She had to, be a co-patient for her mother during whole her chemotherapy and radiation therapy period. So basically, we as a unit, we I think 8 doctors. She missed, we are 7. So we covered for her all her duties. Yeah, this is the time that she returned back.
Wonderful.
Yeah, so as Sudanese, this is our normal behavior.
I see. Yeah, we have a couple of colleagues at my organization that are, have some, disabilities and have some chronic medical conditions. And yeah, I think that, it is important to be supportive and compassionate, to ask about them. It's actually interesting because in the answer, in the explanation to this answer, it is suggesting that we do, I think, all the things that you guys discussed. What's normal, what you normally see, or I'm sorry, what you normally experience, your normal experience is what we should be doing, actually, I think, is what the explanation for this question was saying. So I just think that's so the explanation further reinforces that how you guys react to colleagues is very appropriate, and I think it's important for us here, like when we practice here in the US, it's important to keep that in mind, because it's a big deal, because as physicians, that's like our identity. We think of ourselves as physicians first. Somebody asks you, tell me about yourself, you say, well, I'm a physician. So when that is threatened, my goodness, it's very psychologically difficult. So, yeah. So, yeah, it makes me think, are there opportunities for me to be more supportive of my colleagues who are having chronic issues? It makes me think, I need to be on the lookout for those opportunities to make sure that I act appropriately. So anyway. Okay, any other thoughts or comments before we wrap up?
Thank you so much, Dr. Murad. It's really interesting session and so informative. Thank you so much.
Oh, thank you. No, I appreciate it. So we'll look forward to doing this again next week. I hope everybody has the link now. So please excuse me for that. I really enjoyed today's session as well. I learned a lot from you guys for sure. So this will be uploaded to YouTube. And I'll be honest, I'm starting to listen to this myself, actually, on YouTube. I'm starting to, it's kind of weird listening to yourself talk.
Yeah.
Actually, it's bad because my wife tells me I like to hear myself talk. I said, well, that's not fair. But actually, that's why when you guys participate, it's actually very helpful for me, and I can actually listen to this as well. I really learn a lot from you guys. So no, thank you so much. So
thank you, Dr. Murad. It was a very interesting session. Thank you so much.
Oh, my pleasure.
Yes, thank you very much.
No,
Thank you. Really enjoy it.
No, thank you guys so much for participating. So, let's do this again next week. Hopefully you guys have the link, and that concludes our session today on how to break bad news, part of our the Medina Clinic's medical education series. So thank you guys so much, and we'll see you next week.
Thank you so much.
Thank you. Have a nice one.
Bye.